Thank you, Dr. Hicks, and thank you to Guillermo for the invitation to speak and actually speak on a topic that I know very little about. I'm miscellaneous here today. So I am a renal pathologist, which means that 99.999% of what I do is kidney. But once in a blue moon, a different specimen will come through our lab. And they'll always say, take a shot at it. And I said, well, sure, why not? Because if it doesn't work out, then I can send it to the Mayo Clinic or to one of you guys. So this was one of those cases, and then actually it's the first time I've ever diagnosed it on the first specimen that I got. So the title is Strokes and a Skin Biopsy. Here's the clinical history, and it's important here. So the 50-year-old female with morbid obesity, hypertension, she has an MGUS and she has diabetes. She initially presented with migraines, weakness, this brain fog, and neuropathic pain. So if you look at those symptoms, and especially the neuropathic pain, initially it was sort of written off as diabetic disease or secondary comorbidities due to diabetes. The question was what we were going to do with the MGUS. She had been diagnosed with multiple sclerosis 10 years prior. However, she had tried multiple disease-modifying treatments for MS, and she had zero improvement clinically and subjectively. So then she came to Cedars-Sinai for a second opinion. And when she got there, the neurology team at Cedars reviewed sort of her entire medical history and looked at her, including the imaging, the multiple brain images that they'd done. And they thought that her MRI changes, the white matter lesions, were actually not consistent with MS at all. And they were concerned that there might be some sort of ischemic etiology because they look like ischemic infarcts. So you might be wondering why we got a skin biopsy on a patient who comes in with possible MS and potentially ischemic infarcts. And this is because there already was a diagnosis that was in place, but in nature, I'm going to, take some dramatic license here and present the case in a little different way. So I'm going to start with the EM. So I already knew just from the clinical history that we were looking at some sort of vascular etiology. So this was the first vessel that I looked at, and it was a punch biopsy, sort of deep thickness punch biopsy. There was no inflammation, no evidence of inflammatory vasculitis here. So we focused in on the vessels. So if you look here, here's an arteriole, and just to orient you, you've got your endothelial cell here, your smooth muscle myocytes here, and then in between, you've got your basal lamina here, and matrix material. So just looking at this alone, it didn't look all that remarkable to me. Adventitia was okay. There were no inflammatory cells. I didn't see any obvious deposits, so I just decided to move along. On that same vessel, though, if you look on higher power here at the 3 o'clock position, there was this little, what I call the goober. So it's an electron-dense aggregate. It's a tiny one. I just thought is this really pathogenic? Is it anything that's going to be important? So I kind of filed it away and kept on looking. So here, this is not an arteriole anymore, but it's probably a peritubular capillary. And again, you can see the basement membrane here and the adventitia, the endothelial cells. I'm a kidney pathologist. I see a lot of immune complex mediated vasculopathy. So my first my instinct was to look for immune complexes, which I didn't see. We also signed out a lot of transplant. And one of the things that we look at for chronic ABMR is peritubular capillary basement layering. So that was, initially where my eye went to too. And I really didn't see ultrastructural abnormalities. But then again, if I looked really closely, there were again, these 2 little goobers at the edge of this little vessel, and they're punctate electron-dense deposits. They really don't have any organized substructure. It's just this granular material that seems to be hanging out in between the endothelial cells and in the loose matrix that connects, or that's in between the endothelial cells and the myocytes. So what this is called in this particular entity is granular osmophilic material. So from now on, they're going to be called GOMs or GOMs. So here is another arteriole again, and in contrast to sort of the cross section we were getting, now we're getting a longitudinal section. So you can see here the endothelial cells and the myocytes, and now I'm beginning to point out here. Now that I've seen a couple GOMs, now I can pick them out. So there's a lot of GOMs here, all of a sudden, all along the myocytes. And if you go on higher power here, you can look at the myocytes here. Now you can clearly see those electron-dense little punctate deposits here. Some of them appear to be indenting the myocytes here. Some of them just appear to be hanging out in the loose matrix, and some of them are closer, further out towards the outer vessel wall. Nothing in the intima, though, which is sometimes where we see immune complex deposits in, like lupus nephritis, for instance. On higher power, again, you can see they're beautiful, actually. It's this granular osmophilic material. These deposits are forming little indentations on the external surface. They're kind of hugging the myocytes, and this is actually pretty characteristic for this disease entity. So now that we've seen it, I moved to another vessel, and now you can really see it's almost lining the myocytes all along the periphery. So it's almost like little polka dots all along the edge here. So these are the granular osmophilic deposits that are in the vessel wall or surrounding the myocytes, and again here as well. Sometimes the deposits are associated with thickening of the matrix material or the loose matrix of the basement membrane here, which again is also characteristic for this particular disease entity. And here you can see it again, lining the myocytes with thickening of the basement membrane here. So now that you've seen the EM, we can go back and look at the tall blue section, which is what I really like to do because I'm a pathologist. And I thought, well, maybe typically you can see deposits on a good tall blue. And our lab is pretty good, so I thought maybe I'd be able to pick them out. And actually, if you look really carefully and know where you're looking for, you can actually see it. So here's a nerve here, and here's one of the vessels. Really didn't see any punctate abnormalities there. And then this is actually that vessel that we were looking at by EM, that longitudinal vessel. And you can see this blue material here. Some of it's punctate, some of it almost looks linear. I think that those are those granular osmophilic deposits that we were seeing by electron microscopy. Here on higher power, again, I think that these are those deposits. And then here is another vessel here. And actually, on higher power, you can really begin to see those little densities here that are staining tall blue positive. And that's the actual vessel in real life, right? So this is this. So even on a good tall blue, if you know what you're looking for, you may be able to pick out this diagnosis even before you do the EM. So after I got the skin biopsy, the genetic test had already been cooking. So by the time I finished the EM, the genetic testing came back. So the genetic testing came back for a heterozygous variant of uncertain significance. It's a VUS, but actually we know it's a certain significance now because this patient clearly has this disease in the Notch3 gene. And so mutations and abnormalities in Notch3 have been associated with this particular disease entity, which I'm not going to tell you yet, because once we found out that there was a genetic component to this, we went back and the genetic counselor did a really extensive genetic history on this patient. And the things that are in bold are the things that I think are relevant to this particular diagnosis. So really very detailed pedigree, maternal and paternal side, chronic migraines, autoimmune disease, multiple TIAs, dementia, bipolar disorder, mood disorder, anxiety, multiple strokes. So clearly, in addition to an autoimmune component, there appears to be some sort of cerebral, abnormality in this family that's traced back multiple generations. So the final diagnosis was CADASIL. I can never remember this, so I put this in here on purpose. Cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. So it's a genetic predisposition to multiple strokes, and it's also associated with all those different things that you're seeing in the family history, migraines, dementia, diffuse white matter lesions. It can be easily confused with multiple sclerosis. It's not the first time this has happened. And in this particular patient, that's what happened. She was misdiagnosed as MS and came to Cedars and was appropriately diagnosed with CADASIL. There are about 350 different mutations that have been identified in the Notch3 gene. Some of them are associated with gene dysregulation, and some of them are associated with actually truncated forms, which is what I'm going to talk about in a little bit. So the Notch3 gene is a transmembrane receptor. All 350 mutations are out here in the EGF-like repeats. So certain mutations, again, are associated with dysfunction, gene dysfunction, but other mutations actually can cause truncation. So this part out here is truncated and cleaved off of the receptor. And these, they think, are what make up those granular osmophilic deposits that are seen in CADASIL. It's accumulations of these truncated receptors that are kind of accumulating along the outside surface of these myocytes. So how does altered Notch3 affect or cause these symptoms, neurologic symptoms? A lot, actually. So Notch3 is highly involved in smooth muscle development. So if you have abnormal signaling, you can have dedifferentiation that causes fibrosis. You can get leaky vessels that can predispose to stroke. So those truncated forms can co-localize with other proteins that also affect fibrosis and production of inflammatory procytokines. And then importantly, and especially for this particular case, certain mutations that cause truncation or cleaving of that outside surface, those can actually accumulate and form those deposits that we see. And those deposits themselves can incite an inflammatory response and vessel fibrosis, which predisposes to these strokes and vessel injury. So here's a nice little diagram showing you that in a normal healthy vessel, you don't have those aggregates, but in a diseased patient, you get the accumulation of those GOMs outside near the myocytes that can cause fibrosis. And sometimes they can impinge into the blood vessel, causing decreased flow, thrombosis, and et cetera. All those different things that can cause those neurologic abnormalities. So in this particular patient, it's important because the first presenting symptom, and this is almost unilaterally true, is migraine. And that's a very, very nonspecific clinical symptom for a patient to present with, right? So you can see how something like this may be misdiagnosed as chronic migraines or multiple sclerosis or a number of neurologic conditions before they even move to genetic testing or especially a skin biopsy. But eventually, as those deposits accumulate in your brain, particularly, and cause fibrosis and vessel impairment, they can cause stroke and ultimately dementia and death by the 70s, depending on the penetrance of the mutation that you have. So the skin biopsy findings are pretty similar. This is a really nice paper, and it's very similar to the studies or the pictures that I was showing you in our own case. You get those granular osmophilic deposits here around the myocytes. Here again, sometimes they cuff the myocytes. They can be associated with really significant thickening of that basement membrane, which is what we saw in our case, but nowhere near as dramatic as this. They can have different sizes and they can have different textures, right? So the ones that we saw are those really densely granular osmophilic deposits, but you can also get sort of more loosened ones and smaller ones, and you can get ones that are kind of scattered here in the looser matrix material. Here again, just showing you the different textures and the electron densities and lucencies, and also the distribution of these deposits. So skin biopsy to detect these granular osmophilic deposits, it's about 45 to 90% sensitive, and it's really operator dependent. It really depends on if you have to know what you're looking for, which clearly I didn't, but I did a lot of research beforehand, and I was just really lucky that it was a textbook case. But these GOMs, even though they're not as sensitive, they are very, very specific for CADASIL. There are rare other conditions where you can see similar types of deposits, but almost 99% of those cases will end up being CADASIL or a variant of CADASIL. So I thought that it might be a good idea to just show you a differential diagnosis for these instead of just showing you CADASIL. So one of the things that you can think of as a differential diagnosis for CADASIL would be lupus vasculopathy. This is a term that I think is very, very confusing. And honestly, there hasn't been a whole lot of work that's been done since it was initially described. Generally speaking, it's luminal narrowing of vessels due to immune complex deposits in a patient who has lupus. But in reality, there are 5 different categories. You can get uncomplicated deposits or deposits that are just sitting there, deposits that actually cause like an inflammatory necrotizing vasculopathy, TMA, vasculitis, or just nonspecific arteriosclerosis. What I think is really confusing is that some of these can be associated with actual immune complex deposits in the vessels, and some of them are non-immune complex mediated. But for our purposes, I'm going to focus on the immune complex mediated ones. So they think that these immune complexes that deposit in the kidney, they incite complement activation and inflammation, and then you can get vasculitis and you can get thrombosis, and that's how lupus vasculopathy sort of progresses, the pathogenesis of it. This is an actual case, and this is a little arterial, and there were these tiny little red deposits here along the vessel wall. So I know that these are immune complex deposits just because I know the properties of our own staining here. This is a smaller arterial, and this muddy brown stuff, these are all immune complex deposits. So sometimes in this disease, you can actually get almost occlusive immune complex deposits that fill up the entire lumen of the affected vessel. This actually is a peritubular capillary, and I thought that this was fibrin. I thought I was looking like a fibrinoid or necrotizing lesion, but it turns out that these are also immune complex deposits as well. So if you do immunofluorescence, this is the IgG around a peritubular capillary. So that's what I was looking at. So this is true immune complex mediated vasculopathy. And in a really juicy case, this is IgG completely highlighting an entire vessel here. And this is sort of what we look at here. So this would be the light microscopic equivalent, or immune complex deposits in an affected vessel that's just caked with immune complex deposits. On a tall blue stain, and again, this is from that case, you might be able to pick it up because you can see these sort of glassy tall blue positive deposits within the vessel wall. Sometimes they're so big that they're almost occluding the lumen like you see here. So what do you see by electron microscopy? Well, in a good lupus case, you'll probably see deposits in other areas, including tubular basement membranes. You may or may not see tubular reticular inclusion, so these are all things that you need to be aware of. But you may see these immune complex deposits along the vessel wall. And these on low power can look really similar to those GOMs that we were looking at before. The difference is the extent of these deposits in a really juicy case are far more extensive than you can see in CADASIL. So here you can see the immune complex deposits that are all infiltrating diffusely within the vessel wall. Here again, you can see those deposits as well. And sometimes those deposits actually can land in a subendothelial distribution and cause almost occlusive luminal occlusion. And you don't see this kind of distribution in CADASIL. So this is one way that you can kind of differentiate CADASIL between from lupus vasculopathy. So the deposits in lupus vasculopathy can be in your vessels, or it can be in the glomeruli, or really anywhere, whereas in CADASIL, obviously they're restricted to the vessels. You have immunofluorescence to hang your hat on for lupus vasculopathy because you will get typically a full house pattern in those deposits, whereas the deposits of CADASIL are not immune complex mediated at all. They're truncated little proteins, so they're not going to be positive for any immunofluorescence staining. You may see extravascular deposits in lupus, and you won't see it in CADASIL. In lupus, you can see thrombosis and vasculitis, and in CADASIL, in really advanced cases, sometimes you can see thrombosis, but you won't see vasculitic changes. So one other differential diagnosis for an immune complex vasculopathy would be cryoglobulonemic vasculitis or cryovasculitis. There's 3 different types of cryo. You can see over here, this is what it looks like, but just, by grossly looking at the serum as the cryos precipitate in cold temperatures. They think that the cryos in the vessel lumen can either cause mechanical obstruction or thrombosis, or similar to lupus vasculopathy, they land in the vessel wall, activate complement, inflammation, and then you get those vasculitic changes and thrombotic changes. So, and sometimes these cryo deposits are huge and they can occlude the vascular lumen. So this is what they call mechanical thrombosis. In small vessels, you can end up with a vasculitic lesion like this. And this is actually on the differential diagnosis for patients who come in with these types of purpuric lesions, not just ankylosing, but actually cryo. It's one that people never think about, but you should remember. In the glomeruli, they land sometimes in the capillary lumen and they can be occlusive. You can actually pick them out on a really good case by just light microscopy alone because you can actually see the deposits that are lining the intima of the vessels. They obviously have a beautiful organized substructure. This is from one of the cases that I had where it was a cryovasculitic case with actual thrombosis, and sometimes those cryos can incite an inflammatory response or vasculitis. So how do you distinguish this from the GOMS of CADASIL? You look at ultrastructure. Cryo has a really characteristic, beautiful organized substructure of microtubules here, hollow core. Sometimes they form these sort of annular or tubular annular structures here. And in the vessels, sometimes if you're lucky, you can see it. You can see a vague microtubular substructure in the vessel wall as well. This is from the case that I had. A lot of times the cryos are very unstable and they degenerate and you just don't get that beautiful textbook substructure in EM that you might, in a textbook case. So this is a case of cryovasculitis. There are some uncommon substructures as well. I won't go into this, but this is a beautiful review, and you can see that they don't always have to form those annular structures. Sometimes you can form lattice-like arrays. Sometimes you get these parallel, sort of crystalline inclusions. You can differentiate cryo-GN from CADASIL, obviously, by looking at the immunofluorescence staining. Again, you can get depending on the type of cryo, you'll have a very characteristic IF pattern. CADASIL, again, negative IF because they are not immune complex deposits in the vessels. Cryo has that beautiful organized microtubular substructure. You can go on high power in CADASIL and you're not going to see that microtubular substructure. So these are truly granular osmophilic deposits in CADASIL. And then histologically speaking, cryo-GN can also be similar to lupus vasculopathy associated with thrombosis and vasculitis, whereas CADASIL is typically thrombosis. So I am out of time, so I'm going to stop there. If there's any questions, I'm happy to take them. And this will be online, I think, so it's available for you to look at as well. Any questions?